All right. Good afternoon, everyone. It's 12:15, so we're going to go ahead and get started with CPC. We have our disclosure slides up. I'll let Dr. Hunt quickly talk through his disclosures.
Small amounts of stock in two companies that I don't recommend buying.
All righty. So our case this week is a case of a 34-year-old male with a history of Crohn's on Humira who's presenting with 5 days of fevers, abdominal pain, and diarrhea. Before we dive in, I'd like to introduce Dr. Hunt. He's the director at the Emory Division of Hospital Medicine. He's also a professor of medicine over there. He was just recently nominated to be a Master of Hospital Medicine through the Society of Hospital Medicine. That's only been awarded to 43 people in history. He's a fellow of the ACP as well. He did his undergrad studying math at Frostburg State University, did medical school at Vandy, then did his first 2 years of residency at Vanderbilt, and then moved to Baylor College of Medicine for his third year. Dr. Hunt has discussed over 100 CPC style cases at Emory and has a lot of experience with this. He's also done 5 of the CPCs for the New England Journal. Do you have any initial thoughts about this one-liner, Dr. Hunt?
So Hill, I'm so glad you asked. Now I'm going to warn you that I tend to do these types of conferences as full contact. So it's okay to shout out thoughts, but I'll give some of my thoughts up front as well. And so here we have a young patient with Crohn's, fever, abdominal pain, and diarrhea on an agent anti-TNF. So I'm now worried about a number of things, including opportunistic infections, including lymphoma, including autoimmune disorders, et cetera. But we don't have enough here to really start thinking about how urgent is this situation. 5 days, it seems subacute, so maybe we have some time, but we may find out shortly that the patient's blood pressure is 70, and it just took 5 days to get to the ED. Any other thoughts in the audience at this point? Well, I should have asked up front, anybody know this case? That's a real problem when you're doing conferences like this, because there'll be somebody who knows the case who's just really tempted to jump right in and say it's obvious that this is temporal arteritis. Okay, but any other thoughts? Another aspect of how I think about the first one-liner is there are going to be some things that I just don't want to miss, but we'll get back to that in just a few minutes, I suspect. So, Sahil?
I will give you some more information. So for the HPI, this patient had 5 days of abdominal pain. He had initially had fatigue and temperatures up to 102.4, which he did measure at home. He had 1 to 2 loose non-bloody stools. 4 days prior to admission, he continues to have fevers, develops nausea and vomiting, has a little bit more loose stools, but there's no blood there. Still is having fevers 3 days before, and that's when he develops right-sided sharp abdominal pain, continues to have diarrhea. And then 1 day prior to admission, this is what prompted him to come in. He almost passed out. He started having some mild bright red blood per rectum and shortness of breath, and that's what pushed him to come in. Does that help you at all, or is that just non-specific?
Thoughts? Yep. Yep. Wow, great. Dr. Frazier has given us a great way of thinking about this, and this is reminding me, let's go back and make sure this is not the Crohn's itself. Maybe it's that straightforward. Yeah, so maybe this is just Crohn's. Maybe it's an exacerbation of Crohn's. The fever seems a little higher than I would have expected, but maybe. I'd want to know more about the history of the Crohn's. How long has it gone on? How long has the patient been on immunosuppressants, et cetera? Yeah, but we want to make sure we're not missing something. And maybe the patient walks in and says, this is like my typical flares of Crohn's. Or maybe the patient walks in and says, oh, by the way, I had a surgery 2 weeks ago. That's going to be different. And one of the ways I think about potentially infectious issues is to think about the host. This is an immunosuppressed host, the exposures, and then the bugs that might be involved. And so we might come back to that. Oh, it does remind me that we were at dinner last night with some hospitalists, and they brought up the one-liner and said, it's obviously histo. Really? Okay, well, I guess it could be. But anyway, we'll find out more.
You'll find out a little bit more about his Crohn's, just like you were asking.
Oh.
So he said he last felt in his usual state of health 4 months ago because his Crohn's has started acting up recently. He was diagnosed 2 years ago, had some small pericolonic abscesses at that time that resolved with PO antibiotics. And then he'd been on Humira and managed for 18 months pretty uneventfully. About 3 months ago, he started having some fevers and abdominal pain, and he went to his local hospital. He got some IV steroids, and some repeat CT scans were done that showed active disease at that time, and he was discharged on a prednisone taper. He was up-titrated on his Humira about a month ago, and he still remains on steroids. So we're looking at about 60 days on steroids coming up.
So now we know it's even more immunosuppressed on steroids for an extended period of time. And now I'm a little bit worried about the bowel and how it's been impacted by the steroids. So other thoughts that you have? Absolutely. And so it's going back to those environmental exposures, and there might be something unusual there. And so we're going to want to know about that. Absolutely. Other thoughts or questions? Yeah. And so the point is, this is, and I'm going to give you a clue about doing CPCs. It's usually not what we first think it is. Oh, it's occasionally, but yeah, not here. That was helpful.
All
Okay,
right.
so we're now assuming it's probably not the Crohn's, although don't set it aside entirely yet. Yeah, but I'm still bothered by that degree of fever, and presumably this patient is pretty sick once we get to see him.
Let's learn a little bit more. So his fever's resolved after the course of steroids at the other hospital, and then they recurred again, most recently 5 days ago.
Oh.
Still on steroids.
Yeah, that's worrisome. It's going back to the point earlier of this is probably not the Crohn's. If it is escaping from the current immunosuppression. All right.
Let's learn a little bit more about him, just to round out his past medical history. He has a history of retinopathy of prematurity. He's currently legally blind. He has depression, schizophrenia, no surgeries. He's on olanzapine for his schizophrenia and depression. He's on the Humira every week. Omeprazole and prednisone. Omeprazole was only started due to the prolonged course of the prednisone. No known drug allergies. His mother has a history of type 2 diabetes, but no one else in the family with any immunodeficiencies or cancer. He does work on a farm in rural Missouri, and he usually works with cows, occasionally cleans out the chicken coop. But apart from that, doesn't use tobacco, doesn't smoke, and doesn't use any alcohol.
Okay, thoughts?
We are in the summer.
Thinking out loud. What are we thinking about? Thank you. I'm not from Missouri. But we would worry about those types of things. Yeah. And so we're worried about the environment here in this area, and we're worried about organisms that might have contacted here. Okay. Other thoughts? Yeah, absolutely. And so it's, again, going back to that environmental exposures here, and I love the ID notes that go through every possible exposure. I try my best to do all those before they get there, but I have to admit Carlos Del Rio often adds something significant at Emory when he sees the patient. Now, one other thing I'm going to make a point of that probably is not the answer here in this particular case, but medical students in the audience, it's okay to admit it.
We've got a couple.
When we're on rounds and the attending asks in a differential diagnosis for things that might be contributing to that or might be on that differential, medications always appear on that differential, and combinations of medications appear on that differential. Being from Texas, I can say meds with at least 3 or 4 syllables, which buys me enough time to think about which medications. And so I'm thinking about this patient who's on olanzapine, could be an interactive drug and might be causing fever. So I want to make sure we don't lose sight of something like that. Okay, let's get some more info.
All right, so just to round out everything with a review of systems, the only new things that pop up here are the night sweats, the weight loss, but everything else we knew about.
Okay, probably didn't add a whole lot. So now, what are your thoughts? Ah, good. And so one of those things that I like to do in discussing cases like this is begin to put things in a list of tests that we want to see. And so we probably want to know about HIV status. I probably want to know about COVID. I've learned the hard way. Yeah, we're probably thinking about other tests that we might want to do for this patient. And we're going back and saying, I want to be careful about the exam to look for lymphadenopathy. Great, great point. Other thoughts? Absolutely. Yeah. And so tuberculosis is on our considerations here too. And we go back to that TNF inhibitor. That's going to be a black box warning, isn't it? So we're going to keep that on our radar that potentially this is TB. Okay. Excellent. Sahil, I wonder if those safety checks were done.
We will find out.
We will find out.
But first, let's take a look at the patient.
Okay.
So you have a physical exam. His blood pressure is 123/57 at his baseline. His heart rate's 160. He's satting 90% on room air, and he's febrile in the ED to 39.4. He is alert, he's interactive, he's mildly tachypnic, his mucous membranes are very dry. He is tachycardic on exam, but otherwise his cardiac exam was unremarkable. He has some increased work of breathing, and he's got some abdominal tenderness, some right side greater than left, but it is diffuse. And you do feel something that feels like a mass in his right lower quadrant. There was negative Murphy sign, negative operator and SOAS signs. There's no rebound regarding. It was diaphoretic and warm.
Okay.
There was no lymphadenopathy.
Thoughts? Now we know he's sick. He's quite sick. He's very tachycardic. We need to move quickly. He probably needs fluids at this point. We need to be thinking about what we're going to do in terms of supporting him through a diagnostic workup. We got that right lower quadrant mass. What do you think? Yep, absolutely. So a great point, and it's bringing us to that list of things that we're going to do in terms of testing. This patient needs imaging fairly early in the workup. And now I'm reminded, well, could it be as simple as appendicitis with an abscess? Probably not, because he has diarrhea. But I'm worried about abscess, and I'm now worried about a complication from the Crohn's in some fashion. But we're still worried about immunosuppressed state, and could it be an unusual infection that's giving us that mass as well? Okay, any other thoughts? Oh, what diagnostics do you want first? Well, I have learned the hard way that make sure we check the routine tests first. It's really embarrassing to send somebody to radiology and they call you and they say, did you know the creatinine is 15? So we'll do the routine things, but then what test do you want beyond that? We already said we want to know some other status like HIV. We're considering COVID. I'm always considering that, but I'm probably going to set that aside here. And I mentioned imaging. What imaging would you do? Contrasted abdominal CT. Agreed. In fact, there is data to suggest that patients who present to the emergency room with abdominal pain randomized to early CT versus usual care admitted to a surgical ward, the patient's early CT do better. Outcomes are better. So we're going to want to get that at some point. Okay, Sahil?
Like you requested, we'll start with the basics. Here is a CMP for you. You've got a sodium of 128, potassium 5.4, your bicarb is 16, your creatinine is at baseline, your calcium's a little bit low, but your albumin's also low.
Yep.
You've got a direct hyperbilirubinemia, mild. You've got a very elevated alkaline phosphatase at 1144, and some elevated but not as elevated AST and ALT.
Thoughts? And at this point, I'm building that problem list. We've started it already. We've said, history of Crohn's, abdominal pain, right lower quadrant mass. We now see has some degree of hyponatremia, not a big issue here. We see significant elevation of alkaline phosphatase and transaminases. That goes on the problem list as well. And the calcium I'm not worried about with the albumin being low, and this patient is probably somewhat malnourished. And what brought it to mind for you? Yeah. Now, the tenderness is more right lower quadrant or right upper?
It's all across the right side.
Okay.
The mass that you felt isn't necessarily any more tender than any other part of his belly.
Okay. But we'll keep that in mind. The alk phos seems a little bit higher than, or significantly higher than I would expect if there were a discrete abscess in the liver, but we're going to keep that in mind. Good. Other thoughts? Yeah. And so we're worried about that, although the alk phos is pretty far up there. And so we're thinking about that sort of differential of, is this biliary? Is this intrahepatic? Is it cholestatic pattern? Could it be infiltrative in the liver? Good. Other thoughts? Yeah. So hyponatremia often occurs with any illness presenting to the hospital. It's the most common electrolyte abnormality in the hospital. And it's okay to go down the pathway of trying to figure out what's the driver here, but it's not likely to be the answer to the underlying condition. And then there's another point to make here, and that is, do we need to address the hyponatremia aggressively? And the answer is no, because the acute discovery of a problem that may be subacute or chronic does not require acute intervention. That's actually a good rule to remember. I love it. Absolutely. So somewhat hyperkalemic and a little bit hyponatremic. And so we have to worry about that. And I'm particularly concerned he needs stress dose steroids at this point, independent of almost everything else. But we're worried about that. Good. Okay.
He has been faithful to his meds, even though he can't keep anything else down.
And they may be going right through. I'm still worried about his adrenal function. Okay. White count, a little bit low. Hemoglobin, a little low. Not a lot there. Pancytopenic, mildly so. Any other thoughts? Yeah. 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 So great points made there. We're worried about the hypoxemia. We should have included that on our problem list. We're now worried that this patient has inflammatory bowel disease, has some risk of venous thromboembolic disease. It's not going to explain what's going on in the belly, but there may be more than one problem here. And then a great point about maybe this is granulomatous disease infiltrating through the liver. And if I'm remembering correctly, back in the day, we used to think about mycobacterial infections in HIV having elevated alphoses and histo having elevated LDHs. Y'all can Google that and check my factoid there. And I didn't hear. Legionella. Maybe. We'll keep it on our list of possibilities. Didn't hear a lot about cough that I would have expected. Yeah, but we'll keep it on the list. And one of the points about doing full contact case conferences like this is sometimes you can make that diagnosis that seems way out there, turns out to be the case, and you are now legendary in the program. So I'm glad you brought that up. All right.
All right, let's keep going. You get a couple more labs. You'll understand why these were obtained in the ED in the next couple slides. Any thoughts about the elevated coags?
Thoughts about that? Maybe you're as puzzled as I am. Absolutely. Absolutely. And so there may be a consumptive process here that's related to everything else. This patient is quite sick. I'm also worried about the nutritional status, and so that may be contributing to a certain extent here as well. The D-dimer, well, we got it. We're going to have to do that CTA? You were going to do it anyway. Okay, well, it's just like our ER. Everybody gets a CT scan on the way in through triage. Okay, TSH, great.
Yes, and the T-spot that you were worried about was negative.
Okay, well, that's somewhat
Prior to
reassuring.
this. All right, and since you've requested imaging, I'd like to invite Dr. Konstantinov up to discuss some of the imaging.
Okay. So in the ER, one of the first things they did was get a chest x-ray, and on our chest x-ray here, there's no kind of focal consolidation, but there are diffuse interstitial opacities throughout the lungs. And first thought would be pulmonary edema. Alternatively, an atypical infection like a viral infection can present with this with kind of like diffuse lung injury, but looks like pulmonary edema. Then the patient got a CT abdomen and pelvis. They didn't actually get a PECT at this time. So kind of starting from the top on that screen left image, one of the findings was that he had new gallbladder wall thickening. The gallbladder itself is not distended, and we didn't see any calcified gallstones. The wall thickening was a new finding. A right upper quadrant ultrasound was recommended for that finding. For the second image through the pelvis, so that loop of bowel, which is quite thickened and hyperenhancing with inflammatory stranding around it, is a portion of the terminal ileum. It's kind of this long segment of distal and terminal ileum that was quite thickened and inflamed, and then there's small volume ascites in the pelvis. Some additional images. So on the upper left image, there's an arrow pointing to a small bowel intussusception, which was kind of a longer segment than we typically blow off as just transient. It was about 6 centimeters, and the cutoff is around 3. And then he also had some mild mesenteric lymphadenopathy on the bottom left image, and then he did have mild hepatosplenomegaly without any focal lesions. So overall, I mean, the bowel findings, he had gotten multiple CTs over the past several months, as was mentioned, and that was an area that was initially involved by Crohn's, even on more remote priors. So I think the most simple explanation was that it was read as, Crohn's involving the terminal ileum. The other findings are kind of nonspecific, constellation of findings. On the right upper quadrant ultrasound, the main finding was this gallbladder wall thickening, which was pretty diffuse and kind of has the appearance of gallbladder wall edema. There were no stones. The sonographic Murphy sign was negative. The gallbladder was not distended. So this was kind of equivocal for acute cholecystitis. Gallbladder wall edema can be seen in just general hepatic dysfunction, whether hepatitis or chronic liver disease, cardiac dysfunction, or just volume status.
How does that change things for you, Dr. Hunt?
How does that change things for y'all? We started thinking about, I'm going to pick out a number of comments that have been made so far. Could it be a PE? Still could be, but we now have edema, it looks like on chest x-ray, so it lowers the likelihood. So we're probably not going to go down that pathway at this point, but I now have to explain that edema as well. Or is an inflammatory response in the lungs to the septic process. We were worried about what's the cause of the elevated alkaline phosphatase, and does this patient have a cholestatic process of some sort or an intrahepatic infiltrative process? I'm not sure we've excluded that yet. And we now find that the patient has a big spleen. Thoughts? I will take it from the silence that you're as puzzled as I am. But now I back up and I say, is there anything else I could be missing here? Hepatosplenomegaly, hepatomegaly, markedly elevated alk-phos, elevated transaminases, white count that's a little low, febrile, immunosuppressed. So our differential at this point, Dr. Frazier.
We had a lot of histoplasmosis in this region, and histoplasmosis, is endemic in many farm and rural environments, chicken coops, chicken coops, all sorts of stuff. So disseminated histo in profoundly immunosuppressed patients can give people hepatosplenomegaly.
Yeah.
But you can also have bone marrow involvement.
Yep.
We went back to the cows and the chicken exposure, but we didn't really talk about his T-spot was negative, so that's for M tuberculosis, but it doesn't tell you that he doesn't have M bovis, and this is CDC, so sometimes they can do really challenging things here. So he really was working with cattle. You could either have disseminated M bovis, it could be rare, but it's CDC case, or other non-tuberculous mycobacteria, which are prevalent in the water in this region.
Ah.
And could give hepatosplenomegaly, usually lymphadenopathy, and can have bone marrow infiltration as well. In terms the other things that could cause disseminated infections, but not usually hepatic splenomegaly.
Yeah.
So, and then you could worry about development of a lymphoma.
Yep. Yep. So great points. Could this be histo? Could this be something, another infectious process that we're not necessarily thinking about, mycobacteria, non-TB? Absolutely. And I'm backing up and saying, could it be something as straightforward as a viral infection? Could it be mono? I mean, it would explain some of what we see here, but not that mass that was felt, and it doesn't feel quite right to go down that pathway, but you hate to miss something like that. Okay. Yeah, good. So we're going to put Whipple's on the list. Now, I'm going to warn you that sometimes we put things on the list that the probability is not high enough to pursue it right away. And so we'll keep it on our list, but not go down that pathway just yet. You okay with that? Although it's not unusual for me to show up on rounds in the morning and we have a biofire on everything that's been ordered overnight, and like, well, we could have talked to the patient and had a more focused diagnostic workup. So, other thoughts?
We have one up top. Jacob.
Ah, good. And HLH tends to be a CPC diagnosis, doesn't it? And then often you're backing up and saying, what was the trigger? And so sometimes you're looking for that infectious trigger. And so I'm still worried about mycobacterial infections and about histo here. Any other thoughts? And we'll go on. Okay. So, yeah. Yeah, absolutely.
All right,
Okay.
I'm going to take
See
you
you.
through the next few slides for the sake of time. So GI gets consulted for this concern of cholestatic pattern. He undergoes an ERCP. There was a biliary sphincterotomy that was performed, but the cholangiogram itself was mostly normal. There's some like delayed blush that ended up in the gallbladder, so they were concerned about some cystic duct tightening there. But they did put a plastic stent in the common bile duct. So they called general surgery, and he went to the OR. And I've got some pictures from the operative room. There was an inspection of the abdomen, so they initially started laparoscopically, and they saw an inflammatory mass around the terminal ileum, as well as some peritoneal white spots that felt firm. But then they saw some green fluid within the abdomen that was suspicious for perforation. And they converted from a laparoscopic case to an XLAP and performed a hemicolectomy, because that right lower quadrant mass was very concerning. And they actually found a partial small bowel obstruction. And grossly, the bowel was consistent with that. The patient is then transferred to the ICU for his postoperative course. He does feel a lot better. He's still having fevers up there. He's still on oxygen. And he is on antibiotics at this time. He's on Zosyn. There were some blood cultures that were obtained at the very beginning. There are no growth at this time. They do get that biofire that you just mentioned and a respiratory viral panel that was negative. They sent some of that peritoneal fluid off. For a bacterial culture, there's nothing that grew there. And it's sent off for cytology as well, and there's no malignancy. And the path is cooking.
Thoughts? Much of the differential that we've worked to so far is still in play. Could this be mycobacterial involvement? Could this be histo? Could this be lymphoma? So I'm not sure at this point. And we're going to need to have pathology help us with this.
They did not, but they are currently looking at the bowel that was resected and the lymph nodes that were resected with it.
Currently, like right now?
Yes. There's going to be a little bit of a delay in your path results. They ran out of some stains.
I'm sure you did.
It's the weekend.
It's the weekend. Any other thoughts? I need the path at this point. Okay,
All
go.
right, let's keep going. He developed some shortness of breath and chest pain a few days into the hospitalization. Now you might ask what happened in these 10 days. There were some surgical complications. There was a complicated post-op course with an anastomotic bleed. You got an IR intervention. And you do finally get some initial pathology results. There was significant mucosal ulceration, acute and chronic inflammatory components, and fibrosis with macrophages. No discrete granulomas. And then the lymph nodes appeared negative for metastatic carcinoma. You're still waiting on some stains to come back.
Okay. Now we have to deal with the shortness of breath and the chest discomfort, and now we go back to thinking maybe this patient has something that we have missed, and so maybe this patient, in fact, now has a pulmonary embolism, or maybe it'd be remarkable if he didn't get an echo. Did he get an echo?
He will, and he gets an EKG, which is on screen for you.
Tell us how that's going to help here.
There's some sinus tachycardia and some low voltage in your limb leads.
Thoughts?
Not quite beat-to-beat variation.
Yeah,
But-
that caught my eye too, and I started thinking, what's the heart swinging around in the pericardium? Well, let's see the echo.
Before that, you get your CTPE.
You finally got it.
There was no PE. There's some new moderate pleural effusions bilaterally, and in the lungs, a septal line thickening, kind of some areas that are a little more confluent, ground glass, but mostly this looks like pulmonary edema, kind of at least moderate, or you could potentially throw atypical infection in there. And then on the screen right, so there's a moderate pericardial effusion, and the right heart looks enlarged relative to the left, which was a new finding. They also got the abdomen pelvis, and so on the top left, you can see a common bile duct stent. The gallbladder is kind of decompressed with some gas in it, and the spleen looks enlarged still. On the coronal image, you can see some suture line where they did that partial colectomy, and mostly you see post-surgical changes and then kind of diffuse abnormality throughout the large and small bowel. On the coronal image, the large bowel is kind of those lower loops of fluid-filled bowel that look kind of hyper-enhancing, and then all of that bowel in the central abdomen is small bowel, which looks thickened and has some mucosal edema. So enterocolitis, worsening ascites, and post-surgical changes. Some lymphadenopathy as well, centrally there.
And then you get your TTE.
And Sahil, the reading here?
Tachycardia, large
Well,
pericardial effusion
Thank
with
you.
signs of hemodynamic compromise, such as respiratory-mediated variation in the tricuspid flows. You've got a small LV cavity, marked septal flattening, normal EF, and no respiratory variation in your IVC.
Okay, thoughts? Absolutely. So we need cardiology's opinion about what do we do about this pericardial effusion? Absolutely. Absolutely. And so we're concerned about, can we get more fluid to try to make a diagnosis here? And there may be enough fluid in the pleural space to do the same thing. And probably at the same time, we're thinking about how can we improve hemodynamics overall. Yeah, but I want cardiology's opinion here.
And to check in with the other cultures that have been sent along this time, you've sent off fungal cultures at every point in this with every piece of fluid, and nothing has grown yet.
Okay.
But we're only on hospital data.
But you have omitted mycobacterial cultures.
Yes, they're cooking. The last aliquot is going to reveal the diagnosis. Would you like any last labs? You're able to ask for anything, and I'll give you them if I can.
Thoughts?
that group of information may or may not show up on the next slide.
So I mean, those are things we want to see here. And I want to know about AFB cultures and smears that were done.
His HIV was negative. His CMV was also negative. So both, and then they did a PCR. Both of those. Like, all of his CMV testing was negative.
Okay.
Got a monospot that was negative.
Oh, good. All right. Sahil, you got me.
Okay. So here are the fungal cultures we were talking about, and the fungal studies we were talking about. The galactomannan was very elevated, but his histoantigen was above the upper threshold for the test. He also had histoantibodies that were very elevated. His COX-U was reactive too, but all of the fixations were negative. Your mold cultures finally come back from your blood, your pericardial fluid, and your peritoneal fluid about 20 days later, and they all grow histoplasma. And you finally found that GMS stain for your intestines, and there was full thickness involvement with fungal yeast forms. So this is a case of disseminated histo with terminal ileitis, peritonitis, and pericarditis.
Great case. And I think we brought up histo very early on in the differential here. So terrific work from the audience on that. You should give yourselves a hand. And those hospitalists I was talking to last night, did y'all know this case? Yeah. Okay.
All right.
Teaching points?
Thank you for that excellent discussion. I'm going to take you through the rest of the patient's hospital course and a couple of brief teaching points. So cardiology was called, and they did put a pericardial drain in, and they got 500 cc's out. His LFTs worsened, 5 or 6 days in, and they actually think that his stent collapsed due to pressure from like another ball of histo that was growing in the interim. So they had to go back in and exchange that stent. He was initiated on amphotericin for induction for about 12 to 14 days, and then transitioned to itraconazole. In the midst of this month-long hospitalization, he got a VRE bacteremia and completed dapto. He returned for stent removal and was doing well at that point, and then has been lost to follow-up. So some quick learning points. We honed in on this immediately, which was the risk of opportunistic infections and atypical infections with TNF-alpha inhibitors. Specifically, TNF-alpha is necessary for macrophage activation, granuloma formation, and granuloma integrity, and that's probably why there weren't any granulomas on the biopsy itself. This was a very uncommon manifestation of the histoplasmosis. The gastrointestinal histoplasmosis does, has a predisposition to the ileocecal area, which is what we saw, but it's also a rare manifestation. In terms of the pericarditis, their case reports, there's 10 results if you search histoplasmosis pericarditis on PubMed, and the case reports go back all the way to 1961, and they think that it's an immune-mediated reaction, but in our case, he did grow histo from his pericardial fluid. And then the peritonitis that occurred, so that studding that we saw in the OR was also thought to be histo, though it wasn't biopsy. Nowadays, the prognosis is actually pretty good for disseminated histo, especially with the introduction of amphotericin. Before that, this had a 80 to 90% mortality, while now we're looking at a 90% survival rate. Can I get another round of applause for Dr. Hall?
Thank you for the opportunity to come do this CPC, a fantastic learning case. One last point I'll make that Sahil kind of skipped over. I hope all of you have a chance to do CPCs. It is not unusual at the end of that discussion to hear, this would be the 11th reported case in the world literature. So thank you for that. All right, thanks for being here.